So just when starting on the management of hyperacute, I think it's always important to get back to basics. And so you're all familiar with this diagram. And some basic understanding of neuroanatomy. It doesn't have to be particularly fabulous to have an understanding of how acute stroke medicine plays into this. But we're all familiar with this, and as a consequence of understanding this, we understand that the motor homunculus and the territory supplied by it will give you an idea of the indication of the type of strokes people are getting. So basic neuroanatomy is not essential, but it's nice to have. And of course, then the striatal vessels and the small vessels that cause majority of the lacunar type syndromes are documented there. So this is just a pictorial representation of, I guess, almost an idiot's guide to the brain, and in particular, how it presents in stroke syndromes. So we're aware of the frontal lobe and executive function, motor around the frontal and precentral gyrus, the sensory integration of sensory input, both spatial and calculation to language, integration of visual input, and temporal lobes to do with language, memory, emotion. Of course, the back of the brain to do, or the cerebellum to do with coordination, and the conduit of the cranial nerves. And as a consequence, strokes of your frontal lobe are going to give you, on this side is the left hemisphere, so right, paresis, executive, expressive dysphagia in the frontal Broca center, motor dyspraxia, executive dysfunction, emotional lability, continence, 2-point discrimination, right homonymous hemianopia. So, in a nutshell, that's almost every stroke syndrome you'll see. And of course, the nature of understanding hyperacute stroke medicine is having some idea of the territories that you're affecting. So, the 80% of the cardiac output goes through the anterior circulation through your carotid arteries, 20% through your posterior circulation, your vertebral arteries, and you would have come across the circle of Willis, which is a nifty little evolutionary advancement for human beings, whereby we're able to connect our anterior and posterior circulation together via the ACOMs. And the collateralization of those ACOMs and PCOMs play a key role in neural recovery post an acute infarct. Just a little bit about the posterior circulation. I think we recognize that, you guys all know that, and the brainstem stuff. The one thing about the brainstem, it does everything, and so there is really those are the things that you guys can think of. In terms of vascular territories on a CT scan, going back to basics, the key is working out an area or an artery that you think is affected when a stroke happens, and having an idea of its representation on a CT scan is useful, and I thought this was quite a nice picture. And also don't forget about the watershed or the border zones. So the border zones between ACA, MCA, MCN, and PCA. A lot of our patients will have some degree of hemodynamic compromise, whether that be due to arterial disease or cardiac output problems. And so it's quite common to have a watershed type infarct. I'm going to concentrate the talk mainly on ischemic strokes, mainly because there's a lot of stuff we can do with them, and hemorrhagic strokes are a bit trickier, and I won't really mention much about it unless people want to talk specifically about. Really, only blood pressure is the only thing that has made much of a difference in outcome in terms of blood pressure control from a hemorrhagic stroke perspective. But we go down to ischemic strokes. I think the key to ischemic strokes is to try to simplify everything as much as you can. And this is The Oxford classification, I don't know whether it's commonly used in Sri Lanka, but I would expect it to be used all over the world. It's an idiot's guide to stroke, and what it is that it beautifully in one table tells me as the clinician at the other end what's going on with the patient. And not only that, it gives me some idea of mechanism and some idea of prognosis, which is not often you can tell people. So your patient comes in with what's considered a total anterior circulation infarct. I can tell that family member at the doorstep that I need to do some intervention because there's a 60% chance this person's going to die. I know that data at minute 5 of seeing the patient. That helps a lot with decision making. And so it's a very useful tool, and I think if people are using this instrument, this would be particularly important. The other thing for me is, receiving a phone call from registrar at night who says, I've got a 72-year-old who has a dominant total anterior circulation infarct. So I know what it is. NIH score, so I know the severity. And we usually use a modified ranking score, which is a degree of what their baseline's like. So if you're going to tell me someone's got a dominant tax NIH score 20, MRS 0, I don't need any more information. I've got everything I need to know. It's a large vessel stroke, really highly functional person who is, and that's a severe stroke. I don't need you to tell me whether they've got Gaze palsy or, whether there's something going. I can't be sure if it's neglect or not, and all that sort of, the neurology of it all comes out of it, and it just becomes quite straightforward. So I trust that this is in use here, is that correct? Yeah. And so what the Oxfordshire classification misses, of course, is the nuances of stroke medicine, and it doesn't really tell you a lot about the types of vessels affected. It doesn't tell you a lot about mechanism. So we know 80% of strokes are ischemic. Your cardioembolic is a big issue and easily addressed and fixable with the appropriate medication on board. Well, hemorrhagic stroke in my, certainly in Britain and Australia, would be the two most common would be amyloid angiopathy given the age, and hypertension by far is the most common. And so that's the pathogenesis of strokes. So look, we'll go into what happens when someone presents with an acute stroke through your emergency department. And this is how it's done in my centre. So you've got 3 paths to go down. You've come in with your acute stroke, and thanks very much. You've come in with your acute stroke, and your option is medical management. And so that's, firstly, is this a true stroke? Is it a TIA? Is it a minor stroke? And then where do I go to from there? We've got the IV-TPA pathway, which is commonly in use here, and I think you an experienced centre with this. And where you're less experienced with this, the endovascular clot retrieval type issue, which is actually really a relatively new thing. I think it was 2015, they had the 4 sentinel trials come out, so that's around the world. So we're only 6-7 years down the track. So for it to be, it's not really even mainstream, particularly even in an Australian setting. So I thought let's deal with the low hanging fruit first, the easy stuff, the stuff that we can do something of quite quickly. So the TIAs and the minor strokes, well, I mean, you guys know what a TIA is. So it's presumed of vascular origin, affecting the brain and the eye, sudden onset focal episode, less than 24 hours. The issue with TIAs is we know that this is what a TIA looks like in a lot of terms. So this is an MRI DWI sequence that's showing us someone coming in with an acute, short-lived focal neurological episode and have actually had a stroke. And data that's more than 20 years old will say that up to 60% of all of our patients presenting with what's presumed to be a transient ischemic attack have actually had an acute stroke. And therefore the management should be no different. And so attacking TIAs is a big deal. And I think this is a score that you guys are familiar with, the ABCD square score that is universally accepted across the world, and it remains the gold standard for triaging severity of or likelihood of progression to a stroke. And as you can see, the higher the number, the bigger the chance. So you score an ABCD square score of 6 to 7, you have a 24% 7-day stroke risk, and almost half that, 50%, will have a stroke in 3 months. So TIAs, from a population-based perspective, are actually going to make the biggest impact on what's coming through the door at your hospital and how you manage that. And this Express study was it's quite a nice study, and what they found was if a TIA were to present through a GP or through the front door of an emergency department, that if you're able to intervene with the strategies that we're all aware of, so whether that be a statin, an antiplatelet, and an antihypertensive drug, that has a major impact on their future. So if someone comes in, you're diagnosed with a TIA, you say, go off to your primary care physician or go, here's some aspirin, off you go. Unless you prescribe those 3 drugs and those people take them, we can see that their 90-day reduction in stroke after an early intervention. So they've come in, they've had an acute focal neurological event, you've given them the triple therapy that you expect them to be on. You'll have, and from a population perspective, that has a huge impact. So I guess having a look at how you guys manage your minor strokes is a big issue in terms of certainly costing economically and for the patient. Dual antiplatelet therapy in stroke and TIA, well, 3 probably decent trials. The first one was the CHANCE trial, which is a Chinese study that showed if you came in with a minor stroke or a TIA, your 30-day, there was a significant 30-day reduction if you put people on aspirin or clopidogrel. That has been criticized due to the clopidogrel's got lots of phenotypical metabolism issues. The Chinese population is very different. It has a very high vascular risk profile that are untreated. It also has a very high, that population of people have a lot of high intracranial disease, and intracranial disease has been shown to be highly responsive to dual antiplatelet therapy. So that trial has been criticized. The second trial was a point trial, which was done in Caucasian populations. Did show that aspirin clopidogrel probably was useful in an acute, in a minor stroke and in a TIA. The third trial was ticagrelol, which I don't think is available here. It's a newer GTB inhibitor that doesn't have the same polymorphism problems that clopidogrel does, but actually that didn't really show fantastic results. So in summary, somebody comes in with a TIA or a minor stroke. In my setting, what we do is aspirin 100 milligrams, I give them a loading dose of 300 milligrams on the door, and then 75 milligrams from there on for a maximum of 30 days. We know that more than 30 days is probably too much, and these patients will bleed. So dual antiplatelet therapy is useful, does help in a short period of time. Right. So that's all I'm going to talk about from a medical management point of view, because the studies around blood pressure and statins are much the same. Nothing's changed since the late 90s. We're still doing the same stuff. So it's aspirin, it's antiplatelets, it's statins, it's antihypertensive number 1. and good diabetic control. And of course, you've got your lifestyle stuff to do with smoking and alcohol. So nothing really changes for what we can do in that acute setting when someone comes through the door. So the next one is the IV TPA. So an ischemic infarct happens when you have an arterial occlusion, of course, and you end up with dead tissue. And the dead tissue is what we call the core. Around the core is the penumbra, and then there's the oligemic zone, which is outside of the survivable area that is potentially at risk as well, and it's probably relying heavily on collateral blood supply to that area at that time. And so what happens to penumbra? Well, within minutes, you have some degree of neuronal death. If you don't open that up, the entire area becomes infarcted. If you open up the artery, you're left with the little core that you ended up with, but you save a lot of tissue. And so we know that that penumbra that we're all trying to save with IV TPA, that actually stays alive for a lot longer than we think. So 30% of penumbra is still survivable at 18 hours. So whilst we've got the windows at the moment 0 to 4.5, you can see that 50% are still open. You've still got a potential of saving susceptible tissue at that point in time. I'm not sure how relevant this is, but I just thought I'd quickly run through some of the initial trials. I mean, this is old data. This is from 95. These are where TPA was shown to be useful. And I guess I'd get you to look at the modified ranking score. So death, 4 to 5 is quite severe disability, 0 to 1 is basically on full independent. And so we found with TPA that there was certainly a tendency to an improved outcome, particularly a good outcome, so that's 0 to 1. And I think the other thing that was quite controversial at the time is, are we saving people from, so people who would have otherwise died, we're saving them to be severely disabled instead. And the point is that really, if you look at the death column, if you were going to die, you were going to die. TPA did not save you from your terrible stroke, put it that way. And this is the same thing about MRS scores. What was this one about? So this is just looking at a head-to-head on lots of trials with IV TPA within 6 hours, and they all show some degree of favourable outcome. And the odds ratio is just there too. So in summary, we know that thrombolysis for ischemic strokes keeps an extra 12 people alive and independent. I mean, this is a critical thing with IV TPA, is that it's not about keeping them alive, it's keeping them alive and at home. We know that there's an extra 8 people are better off if you can do it between 3 to 4.5 hours. I would like to put a flag out for stroke units. Stroke unit care, this is all in comparison. So this is, we put a lot of money and a lot of emphasis onto funky stuff, and things like stroke units. We're able to resource our patients together. We're able to cohort them in a geographically isolated area with some degree of expertise of nursing and therapy and doctors in that section of a ward. We know that 5.6 out of 100 patients are better off. So there aren't many interventions that we have in stroke medicine that are better than a stroke unit care intervention. So I only put that in just to harp on about stroke unit cares because it's a bit of a pet peeve of mine, because even in Australia, we have lots of units that still don't have simple things like stroke unit care, yet are administering IV TPA. So we just have to sort of work out where we are with those things. With TPA, this is something that we give to our patients and their families when they arrive. It's a nice pictorial representation of the benefits of thrombolysis. because often when you're talking to families, and probably mainly the families, not so much the patients, about what's happening, understanding this complexity is quite hard. I'm going to give you something that's going to break up your clot, but it might cause you to bleed and die. But am I bleeding? Am I clotting? You know, like, people don't really understand. So if you're able to simplify it, I think it makes life easier for everyone. And so this is a nice pictorial representation of what happens when we often point to the 3 in the red and look at how much the green stuff is. So about a third of people are better off. And these are our dreaded complications that we all don't feel so good when it happens. And the scoring system is actually based on the initial trials, and we still use them, HI2 and PH1. So we have an understanding of what type of bleed, what type of hemorrhage people have had post administration of IV thrombolytic therapy. And so the risks, I think, given that you guys are doing it, will understand that the risk is obviously the agent, so how much you're giving to people. So I'm not sure what alteplase has been the one that's been used all over the world. We in our centres have switched to tenecteplase. It still isn't approved without intra-arterial or thrombectomy at the same time. Tenecteplase is what they use in hearts. It makes life a lot easier for everyone. I think, is it alteplase for you guys here? Alteplase, yeah. So tenecteplase was easier just because of the dose and adjustment. The dose, as you know, the dose of thrombolytic therapy is a hard one. How much does this guy weigh? 80, 70, 60? So it's not an exact science. And so we know the dose matters. We know the size of the stroke matters. So the bigger the stroke, the more likely you are to bleed. And paradoxically, what we're trying to do is reopen the artery, and when we do, we cause it to bleed. And so recanalization is probably, those are the 3 most common reasons why people bleed. This was a nice study in the NHS, which compared the studies with real life. So the 6 most studies were people just in normal hospitals all the way around Britain. And they actually showed that there wasn't anything particularly funky about thrombolysis. There wasn't anything about the specialist centre that made it possible. And in fact, the outcomes were better, if not at least the same as the trial data. So we know we can do this. We know it's not very hard. And we know that you don't need to be in a particularly specialised centre to be able to do it. So the indications for stroke, for TPA, well, we're probably going to talk about this a little bit, but clearly a stroke onset within 4.5 hours, which still is on the FDA guidelines for when to use IV TPA, although that's changing, and I'll talk to you about that in a second. Obviously, hemorrhage, contraindications. Once again, I think all of these contraindications are a bit hazy now. BP, for example, I tend to bring them down before I give them IV TPA, so we use either labetalol or IV hydralazine and if that's not available, something like a GTN would be probably available here to give them a go. And so, don't forget to TPA. Yeah. All right. So so these are the in yesteryear. So I've got a 77-year-old man. He's coming with total anterior circulation syndrome 6 hours post the event. He's got a nice clot sitting there in his left sylvian fissure. He doesn't open up his artery, and that's what he looks like. And so prior to the advent of IVT, or prior to the advent of any recanalization therapy, this was our problem. And these are patients that I've had relatively recently. So 78-year-old, fit independent, still plays squash, got some minor risk factors. So he had sudden onset dysphagia and right-sided weakness. So we have the luxury in Australia of having stroke centres. So it means that given the way the population is distributed, you have peripheral sites and peripheral hospitals to answer to one hub, and that hub in that middle is called a stroke centre. And so our stroke centre would have 5 or 6 other sites that talk to us. And so what would happen is if a stroke comes in, the idea is to try to divert them as fast as we can to our centre. All of those hospitals are within about an hour and a half of the stroke centre. Can't be further away for it to actually make sense. So this person was presented to a peripheral site, came into a stroke centre, and so here we are, 2.5 hours, 3 hours post the event, and they get thrombolised. And so pretty good CT scan, post thrombolysis, this is what's left. So that's what we do. That's why thrombolysis works. This is the outcome you're looking for. This person is going to be left with not a major deficit from that. And how we do this in Australia from a post-lysis observation point of view, we have them in a monitored bed on the ward, and that's the observations we take. And blood pressure, once it gets above 180, we start to bring it down a bit slowly. And then after the first 24 hours, we try to leave them alone, essentially. Don't stick things in, no catheters, no lines, unless you have to really rest them in bed. And so that's basically it. So it's not that hard until they bleed. And I guess if they bleed, the truth is, if they bleed, as the British say, your goose is cooked. You take the risk, and there's really not much you can do once they bleed. When they bleed, they bleed. And yes, we do all these things to make us feel better, but the reality is they're not particularly evidence-based, and that's part of the risk you go with when you take IV-TPA on, is that they will bleed and you'll have patients who die. And invariably, there's not a huge amount you can do to change it. So that's IV-TPA. I'm just going to touch on endovascular clot retrieval only in the setting of imaging, which is available here, and perfusion imaging in particular, which is a big deal in stroke, and is probably, in my opinion, the biggest advancement we've had since I've been doing stroke. So what's the principle? The principle of intra-arterial thrombectomy is, we know that if you open a vessel, people are going to do better. So people are going to have favourable neurological outcomes, aren't going to die, and aren't going to bleed. So opening an artery is the key to what we have to do in stroke medicine in an acute setting. And so pulling out that clot is what we're looking for. And we've just discussed IV-TPA, but we know that IV-TPA has got lots of issues. It's systemic. Only about 8% of patients are eligible for that really tight window of 4.5 hours. There's the risks of hemorrhage, of systemic problems. And when you hit a large vessel with a clot, really IV-TPA doesn't have fantastic recannulization data. So you give it a go, but it's probably not going to work brilliantly. So that was the paradigm that we had. And so we knew that, so this is about length of clot. So you're going to have much favorable, if you've got a really short segment of clot, you're going to open up the vessel. Whereas if you don't, if it's quite a length of clot along the vessel, you've got really not very much chance of opening up that vessel. So there's a problem. 35% or so, it's probably a bit overcall. Let's call it 30% of strokes are what we call large vessel. And these strokes we don't seem to be able to do very much for. And the main areas are the ICA, MCA, and your vertebral basilarity system. And the trouble is, when you have a large vessel stroke, you can do very badly. So very high mortality rates, very high disability rates, particularly in the basilar artery setting. And so what changed things was retrieval devices. So they came up with the stents just like we had in the hearts, and we were able to, the tech companies who made lots of money out of this, were able to come up with retrieval devices that seemed to make the difference. And then, so these were the trials in maybe 20 years ago where they were sort of okay. They seemed to help a very defined population, but these last trials were the main ones that changed the game. So this happened, all of them are showing a tendency, so essentially they were all going head-to-head, stents versus IVTPA, and these 4 here at the end were the major ones that changed the way, so we put it, the developed world thought we needed to do medicine. So these 4 trials are the big ones. They all came out around the same time, about 2015, 2016, and they all went for primary outcomes that were good recoveries. And to pool all those trials together, this is what you ended up with. So 311 patients out of all those trials, and we saw that MRS 0 to 2, so that's a good outcome. Numbers needed to treat was 4. So that is, there's no intervention that I can think of with that degree of improvement. So that changed the landscape entirely. And certainly for stroke medicine it did. And so, not just MRS, this is just different showing, I guess. But the other thing, of course, to look at is mortality rates were relatively the same. And the critical thing is the safety endpoints were excellent. So MCAs, bleeds, site hematoma was very small. So this is a relatively safe intervention with big outcomes. And so the conclusion of the endovascular thrombectomy stuff was, look, it's highly safe and it has a big event. So you've got a very big large vessel stroke that's going to render you dead or severely disabled and you're walking out. So, and they were, carefully selected by imaging. You needed to be fast, and the technology was certainly better. And so that was a summary of the outcomes from those trials. So the first 2 trials were the early ones. The last 4 are the more recent ones, and that's the data that would be quoted for its use everywhere in the world. So about 311 patients, I'll give you that as well. All of those are 311 patients, so not huge sample size. So why am I talking about clot retrieval? I'm talking about clot retrieval in the center without clot retrieval because there are some pretty important lessons to be learned from that at the moment in time. And this is a patient of mine that I think maybe 2 or 3 months ago. So he lives alone. He's a time of onset that's unclear. He presents to the emergency department confused dysarthric. He's got a sort of right MCA syndrome. His NIH is 18. His daughter over the phone says he's had exactly the same presentation several years ago. So that's all you have. There's no one here that would think this man is eligible for thrombolysis based on any of the criteria that we have discussed from the FDA and what is possible. And part of the reason is the reliance on CT brain scans. And we rely on the fact that based on a plain CT, we're able to directly visualize the clot, rely on loss of grey white matter differentiation, loss of insular signs. So those are your classic 3 early signs of stroke. And there's the aspect score that, I'll tell you the last time I had a look at that, but there's the aspect score that we used to do. And of course, we go back to the anatomy and what we're looking for on a CT scan, but in essence, what we're seeing here is the hyperdense MCA sign that we recognize. We can see that there's, this is the loss of grey white differentiation. And then the insular ribbon sign, so that's a normal insular ribbon, and there's your loss of your insular ribbon. And so on the CT, what happens in the evolution of an infarct? Well, over days, we either get some hemorrhagic transformation, or it just gets blacker. So in essence, I guess the point I'm trying to make is that this is not a science. We have the ability where I'm at to receive the imaging on my phone. So you're having a look at the imaging on the phone and you're able to differentiate grey white matter differentiation, subtle things up high or edema on a plain CT. It's not easy. So you've got a chap like this who has presented as he has, and this was your initial CT. So your CT has confirmed what the daughter says, that he probably did have an event that affected, it's the wrong side, anyway, let's pretend it did. That did affect him, and it is a long guy, sure, yeah, it is. So I thought I mixed up the imaging. No, she's confirmed it's correct. Yeah, look, he's had a probably vasovagal infarct. That would explain why he was dense. That's one side. He ran improvement. How's this going to guide me? I mean, the guy's come in looking like he's come back in. He could be, you know, the question here is we don't have a time of onset. This could be a seizure. This could be a mimic. Could be anything. And of course, the lay of the land has now changed because of thrombectomy, because we now have this thing called perfusion scanning. And perfusion scanning is the biggest thing that we've been able to have an impact on the lives of our patients. And what we can see with this chap is, and I'm just not sure about because there's lots of different types of perfusion scanning. This is the one that we have in our centre. And so what you see is that the man has come in with a syndrome that matches this. The green is all the penumbra, the red is the core. It gives you a calculation at the bottom of the mismatch of 139 mils. So you know it's going to be a big event, but there's potentially a lot of survivable tissue there. And not only do you get that information on a perfusion scan, you also get the vessels. So I'm able to see this man has got an M1 occlusion. So we have a really ambiguous picture. No time of onset. We've got a guy who has got really not a lot of early change on the CT. We've got an M1 occlusion, we've got a nice perfusion scan. So that actually changes the game for him. Now, it just so happens he's at a site that we're able to do clot retrieval, so we ended up getting IVTPA, getting the clot pulled out, and that's what he looks like. So that's a devastating stroke. And this was, and so this is him, when was it? Recently, yeah. So this is him in our rehab unit, 3 weeks after the event. This is him just prior to discharge. And so the point, that left arm is still non-functional. He's walking. He's at home, and I saw him in clinic just before I came out here, and he's walking with one of those 4-prong sticks. And so what this man was faced with without the intervention was probably not death, but high care nursing home. And so just going to do another case just to highlight the issue of imaging and perfusion scanning. So I should have got rid of Gympie. So Gympie is one of the other hospitals. This is a fit independent lady who lives in Gympie. So Gympie is a peripheral hospital to us, and so she was found by them, so 9 a.m. she was seen at breakfast, found by manager 11 a.m., unable to speak, right hemiplegia, and ended up coming through, had a CAT scan up at the peripheral site, and then ended up coming to us at our stroke centre. So there's your classic story. You don't have a time of onset, so you got to do some investigatory journalism. You got to sit there going, when did you last text somebody? So you're aphasic, or she texted them at 10, they must have been well then. So all of this nuances, the kind of non-scientific nonsense that we've done over the years, where we give people arbitrary time of onsets. We say, listen, you went to bed at 10 and you woke up at 8, so we're going to call it the middle of the sleep for the time of onset. I mean, this is just made up. It's not science. And just like what we're doing here, where we're trying to work out, well, when did this person actually stroke? How far in the window are they? And so this woman, this is her CT when she turned up at Gympie. By the time she's come to us, she's got an evolving infarct. And so she's got this left MCA syndrome. And I'm just going to show you her perfusion scan. This is a slightly different one. This is an older perfusion scan, which I don't know whether this is the one that maybe you have. This one. The only reason I put this one up is that I couldn't find the one that we have is called MyStar. This one's a Siemens. But how this one works is just as effective. The one I showed you before called MyStar actually does the measuring for you. This one, it's a bit more eyeball. But essentially, you've got cerebral blood volume on the top right, which tells me what's dead tissue. Low flow in the middle, so that tells me there's not really a lot of blood getting there. And then you've got time to drain and mean transit time, telling me that there is a problem. There is essentially marking out what we call a penumbra, where the low flow is, where the hazard or the ischemic zone is. And so here you've got a lady who has got an established infarct on CT with no time of onset, and probably this one and 2 occlusion. And so this woman is contradicting. This woman technically is not phoresis, but I've asked her. And that's what she looked like. So you could turn around and say, listen, the outcome is probably, we have saved something there. There's quite a decent amount of territory being saved here. So what perfusion scanning has done is change the paradigm for which we would use IVTPN. So as a rule, the CT brain scan, I think, is just, whilst it's critical, and of course it's important, bleeding and lots of other issues, it's to use it as your tool for scientifically deciding whether someone's eligible or not is hard. And I think that if you do have perfusion scanning, you have to use it. You owe it to your patients to use it, because none of us are good enough to do this without it. And I think you can see that we are able to use what we have, the IVTPA, to the best of our patients' benefit with the advancement of imaging. And so, whilst yes, we don't have heart retrieval here in Sri Lanka yet, that's still not a big proportion of patients. That's still 10-20% of patients. You're going to capture a lot more eligible IVTPA using advanced imaging. And I think you're able then to feel more comfortable in decision making. It certainly helped me when you weren't sure, like the syndrome as to whether someone's had a seizure, you're not sure, it makes a big, big difference. Right, so that's me. So basically, what I want to highlight to you was, in settings like we have here in Rajapura, you can have the biggest impact on people if you hit TIAs and minor strokes hard. So if you've got an ability to start things early, you're going to prevent those people presenting 30 days later with big strokes. We know time is brain, and that adage is still true, but I would say that advanced imaging has changed the gameplay. So it certainly has changed it for me, and has made life for our patients much better. We know that thrombectomy has been the biggest single advancement in stroke medicine in my lifetime. But as I said, it's even for us. I have to, if someone comes in for a thrombectomy at my stroke site, there's only 2 sites in Queensland. Queensland's a big place. 3 sites in Queensland that do thrombectomy. So I then have to transfer my patient an hour and a half south by ambulance to get thrombectomy. So that's in Australian settings. So to have that commercially available in Sri Lanka would be a long way away. And so I think we just have to be able to maximise what we already have. And I just want to harp on one last time about the stroke units, because stroke unit care supersedes anything that we have. It'll have the much, much bigger population effect than anything else. And that's me. Got any questions, or when I've done before? Yeah. How do we assess them? Exactly the same. So it's become, we don't even ask the question anymore. So for us, how it happens is, because perfusion scanning has changed the game so much, everybody gets it. Unless there's a couple of centres at peripheral sites even doing it now. They get a bit narky unless I have a look at a plain CT first. So if a wake-up strokes happen, they've had the plain CT, I can see nothing. Straight to perfusion scanning, and then we take it from there. So there's no more time of onset. You remember the whole wake-up stroke visitors that you guys probably still do, where what time do they go to bed, and they'll work it out and then go halfway? Yeah, we'll stop doing that. So wake-up strokes are, so you come in with an acute stroke syndrome, whatever it is, provided it's not days old, but some have been found. They slide through a scanner, they get a CT perfusion scan, a CT angiogram, and a CT brain. And even with an established infarct, doing a CTA, I get all the information in anyway, so I'm going to know whether this is carotid artery disease or not straight off the scanner. So, I mean, of course, cost. But for me, if it was me, what I would be doing is probably working out a system whereby we're able to look at a CT before while the patient's on the table. Because it's the timing, the CT happens, they go back onto the ward, or they go back onto the DEM department, then you have to make a decision, then you have to go. It's your real time, your fast time ability to go, yeah, that CT's clean, can we have a CT perfusion there and then, will have a big impact. I'm not sure how you could structure that around that, but what I used to do with some of the radiographers is they used to take, got to be very good friends with the radiographers, bloody hell. I bet they're hard in Sri Lanka just like they're here in Australia. But what used to happen with the radiographers is I'd get them to take a screenshot. Just, can you take a screenshot for me, bang, and just send it to me. Yeah, can we go with perfusion scan? I mean, I think you just got to have to think a little bit out of the box with those ones. Yeah.